Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh. Inshallah, we can start now. My name is Zulwakar, and from Group A, we are going to present procedure seminar 2 consists of ECG, bone marrow aspiration and trophine biopsy, CPR in children and also in infant. So the first presentation will be on ECG. What is ECG? It refers to electrocardiogram. Electron means electricity, cardio means heart, and gram is visualized. So basically, electrocardiogram or ECG refers to how to visualize the electricity that flows through the heart. So these are the tools that we need to do the ECG. The first we need to have ECG machine. And then we have all of those wires with different colors, which are LED wire. And then we have different four colors there, red, black, white, and green, which are the limb electrodes. And then we also have 6 chest electrodes, the recorder paper, and also the data transmission line. And then the steps to do ECG, I believe all of you already done ECG in many postings, especially in emergency. So first we need to wash and hand rub, introduce ourselves and the information of the consent of the procedure, and then position the patient in supine position, and also expose the chest, clean the side of the placement of the lead placement, and place the leads accordingly, record the data and remove the leads off and clean the area and allow the patient to dress and thank them. And then this what we are going to do. The first is the lead placement. So on the left we have 4 different rectangles, and on the right side there are 6 circles. We have different colors that refers to chest and also the limbs lead. So the first white color located at the right arm, the black is located at the left arm, green on the right leg, and the red on the left leg. These are the limbs lead, and then we move to the chest lead. That consists of 6 leads. The V1 is located at the right sternum, for the intercostal space. V2 located at the left sternum, for the intercostal space. The fifth V4 located at the fifth intercostal space with clavicular line. V3 located between V2 and V4. V5 located at the level of V4, left anterior axillary line, and V6 located at the level of V5, left mid axillary line. That is for the adult patients, but ECG in pediatric patients quite different with the adult patients. Basically, we are using nipple line as the guideline to put the chest lead. V1 located at the right sternum of the nipple line, V2 located at left sternum of the nipple line, V3 midway between V2 and V4, which V4 is located below the nipple line at the mid clavicular line, V5 at the anterior axillary line at the same level as V4, and V6 same level as V5 at the mid axillary line. So these are the location of the ECG in pediatric patient. Indications of ECG.
Sorry.
Yes.
Well, okay. For the pediatric patient, as you can see in the picture, is more to infant or neonate patient. So V1 actually we put at the second intercostal space. Yes, you mentioned that we look at the nipples, yeah, because the nipple is already at 4th intercostal space. Actually, you have to identify where is your second intercostal space. So from the suprasternal notch, and then you go below, you can identify first and second intercostal space. Usually the second intercostal space are in between the line there. So you find your suprasternal notch, and then you go below first and then second intercostal space. So that's your second intercostal space. The 4th is already at 4th intercostal lah. And then you go as mentioned lah. So nipple tu je lah, nipple tu nipple lah. Tapi the right anatomical, we say that at second and then 4th intercostal space.
Okay. Later I will update the slide later at the second intercostal space. Okay, the indications of ECG in children. First, we look at the general condition. The patient presented with syncope, cyanosis, or hypothermia. And then we suspect the patient might have heart conditions such as tachycardia, bradycardia, congenital heart disease, myocarditis, pericarditis, perimyocarditis, sign of heart failure, rheumatic heart disease, and also cardiac concussion. And then the patient might present with these seizures that indicated for ECG, and other conditions also such as electrolyte imbalance, Kawasaki disease, Post-operative monitoring monitor the vital parameters, drug side effects or intoxication, also poor physical performance. So these are basically the indications of ECG in children. So the interpretation of ECG, basically first we need to mention the details of the patient and also the situation. And then these are we need to mention the rate of the ECG, rhythm, axis, and then we look to do with P wave, PR interval, Q wave, QRS complex, ST segment, QT interval, also T wave. So these are the normal findings in children. Basically in children, their heart rate is more than 100 beats per minute, and there's also appearance of right ventricular strength pattern in the children, which is typical findings, uh, characterized by T wave inversion in V1 to V3, right axis deviation, dominant R wave in V1, also RSR pattern in V1. And then some of the normal findings in children include marked sinus arrhythmia, short PR interval, which is less than 120 milliseconds, and also QRS durations, which is less than 80 milliseconds. And then there's slightly peak P wave, and slightly prolonged QT, and also Q wave in the inferior and also left precordial leads. So this is the ECG of our children. So basically, what we need to do is we mention the detail of the patients, also the situation, and then we look to the rate. Basically, we already learned how to describe the rate of the ECG. So basically, we look at the peak R over there. Then we calculate the box. So basically, there are three boxes. So this patient basically about 100 beat per minute, the rate. And then also we look for the rhythms. Basically, we use a ruler and then we note all the the R peak. And then we look for the regularity. Basically, this child has a regular rhythm. Also, the axis, we look at the LED one, also LED AVF, and then we look to the QRS, either it is positive or negative. And in this ECG has positive value for both LED one and AVF, indicating there's no deviation, which is has normal axis. And then we look for the other the wave of the ECG itself. So basically, this is an ECG of a healthy 2-year-old boy. Displays many of the typical features of the pediatric ECG, which are heart rate with more than 110 beats per minute. They have juvenile T wave pattern. Okay, they have juvenile T wave pattern, T wave invasion at V1, V2, and also V3. There's the invasion and also dominant R wave in V1, V2, V3. V1, V2, and V3, and also RSR pattern at the V1 here. So basically, these are some of the right ventricular strain, which is a normal typical features of pediatric ECG. So basically, that's all about ECG in pediatrics. If you guys want to know about the rates rhythm, I already put all of this as the hyperlink. You can click on each of the or each of these to read more about that. Okay, thank you.
Any question? If not, you can proceed to second presentation.
So I will continue with the next topic, bone marrow aspiration and also trophine biopsy. So bone marrow aspiration and trophine biopsy is used for bone marrow examination. And it is useful in diagnosis and also staging of various hematological disease, and also to assess the bone marrow cellularity. So for bone marrow examination, we can do aspiration, biopsy, and also culture. But in this presentation, I will present about the aspiration and also biopsy. So what are the indications for bone marrow aspiration and also biopsy? We do the procedure to evaluate a hematological disorder, such as to diagnose, to stage, and also to monitor the therapeutic management of lymphoproliferative disorder, such as in CLL, Hodgkin and non-Hodgkin lymphoma, and etc. We also it is also indicated in evaluation of cytopenia thrombocytosis, leukocytosis, anemia, and also to evaluate iron status. Other than that, bone marrow biopsy and also aspiration also done to rule out infiltrative infectious diseases and also to investigate for fever of unknown origin, especially in AIDS patient, to as it may reveal the presence of causative microorganisms. So other than that, it is indicated to diagnose storage diseases and also to investigate metastatic carcinoma and also granulomatous disease. And it can also be done to investigate toxic effects of substances such as alcohol and also nutritional deficiencies. Before that, there is no absolute contraindications in bone marrow aspiration and also biopsy, but relative contraindication may include infection at the site and also no consent. Yeah. And also osteoporosis for sternal aspiration if you want to aspirate at the sternal bone. Yeah, and important to note that thrombocytopenia, low platelet, regardless of severity, is not a contraindication. Next, for complications of bone marrow aspiration and also biopsy, it includes hemorrhage, needle breakage, infection, especially at the site, pain, anaphylactic reaction if patient has allergy, and fractures, perforation of major vessels, especially iliac vessels, nerve injuries such as gluteal nerve, and also for sternal aspiration procedure, it may cause pericardial tamponade, pulmonary embolism or infection, and also injury to great vessels of the heart. So equipments that we need are the antiseptics, the sterile gauze, gloves, anesthesia. Anesthesia here, it may include local or general anesthesia, but usually in pediatric we use general anesthesia, and usually most commonly used is propofol and fentanyl, while for local anesthesia usually used for adult is lidocaine. Shrink, surgical blade, aspiration and biopsy needle, EDTA vial, heparin vial, and also formalin. So the anticoagulant solutions are used to keep the sample for it not to be clot, and for later evaluation in before sending to lab, hematological lab. So for the techniques, okay, for the position, we usually do a lateral decubitus position with the top leg flexed and lower leg straight, or it can also both leg can also be flexed. Other alternative position is a prone position. Anesthesia, we usually give general anesthesia for pediatric and also highly anxious patient, and also local anesthesia for usually for adult. Sites, there are 4 sites, but most common site are posterior superior iliac crest. Yeah, it is the most common as it is safe, means less risk for neurovascular injury, easy accessibility because it has less cortical bone. Less thick cortical bone, so easier to penetrate into the bone marrow, and also is less painful. For anterior superior iliac crest, it is an alternative site if the posterior superior iliac crest is unavailable due to infection, injury, or obesity. Then tibia, usually we do at proximal anteromedial surface below the tibial tubercle, and this is done in infant less than 1 year old only. For sternum, it is only done in adult and for aspiration only, not for biopsy, due to its thickness. It's not thick. So for aspiration, we first palpate the iliac crest and also mark the preferred sampling site with a pen. And then we apply a aseptic technique, don the sterile gloves and gown, prepare the site with antiseptic such as povidone or chlorhexidine, and also inject local anesthetic. But for pediatric, we do general anesthesia, so we prepare the patient first. We sedate the patient first before do the aseptic technique and so on. If in adult local anesthetic, we use 10 ml of 1% lidocaine, inject the initial 0.5 ml directly under the skin, and then we penetrate deeper to subcutaneous tissue and also periosteum, and then inject the rest of the lidocaine. Then we make a skin incision using a small surgical blade, and through that skin incision, we insert the aspiration needle with the stylet. Actually, the slide, the equipment slide, I've put some pictures, but it's not there. Later, I will send the new one. So, the aspiration needle with a stylet locked in place. Once the needle contact the bone, then we advance it slowly and rotating clockwise and counterclockwise until the cortical bone is penetrated. So we can reach the marrow cavity, and as we reach the marrow cavity, we can feel that there is a sudden reduction in the pressure. After we reach the marrow cavity, we remove the stylet and use a shrink to aspirate approximately 0.3 ml of bone marrow. We don't aspirate much because there is risk of diluting the sample with the peripheral blood. Okay, the shrink here, some sources say that we need to heparinize the shrink with heparin 1 in 1,000, but some sources said we don't. But if we want to send the sample to the lab, we can use a non-heparinized shrink, and then as we aspirate, we mix the sample into the tube that have the coagulation solution already. So it's just the same. We put the heparin in the shrink, or we put the heparin in the sample tube before sending it to the lab. And then after we have obtained the sample, after we have aspirate, we remove the marrow needle and we apply firm pressure to the aspiration site with gauze for 5 minutes or until the bleeding stops. And we apply the bandage and advise the patient to remove the bandage only after 24 hours and keep the site dry. So that is for aspiration. For biopsy, the initial steps are same as aspiration until we make a skin incision, and then we insert the Jamshidi needle. There is a specific name, a few types of needles, used, but most commonly used is Jamshidi needle for biopsy. Okay, so if we want to do aspiration and biopsy, some kits allow aspiration and biopsy to be done in the same needle. So we don't need to change the needle. So after the aspiration, we change the needle position a little bit, and also we change the needle position to a different area of the bone, so we can do biopsy at the different area. So we don't do aspiration and biopsy in the same site of the bone. And then once we insert the Jamshidi needle and once the needle contact to the bone, we remove the stylet, and then we rotate the needle just like before, just like aspiration. We rotate the needle clockwise and counterclockwise motion while applying the firm pressure, and we advance the needle into the marrow cavity for pediatric about to obtain adequate bone marrow specimen about 0.5 cm. For adult, about 1.6 to 3 cm. And then we pull back the needle a little bit, about 2 to 3 cm, and then advance again slightly at a different angle. This is only to help secure the specimen. After we have secured the specimen, we pull out the needle entirely in alternating clockwise, counterclockwise motion, same motion. And then we remove the specimen from the needle and place it into formalin solution before sending it to the lab. Then same, we apply firm pressure to the biopsy site with gauze for 5 minutes or until the bleeding stops. There is a video actually, but maybe I will show you after we finish all presentation.
So any question? This one maybe need to see lah. Have any of you have seen this procedure before?
During NSS.
Sorry?
During NS posting, I seen this process.
NS posting lah, BMA with 3 fine. NS buat jarang NS buat, selalu medical tu. Usually patient with hematological problem lah. Because this one's too technical lah. If you read tu, I'm not sure whether you can imagine or not how the procedure was done. But the site, all of the site is true lah. Usually we aim at the assist. Most of the time we do at the assist. It's nice if you can see the video. Okay.
Okay, so the next presentation is CPR in children. So what is CPR? CPR is cardiopulmonary resuscitation, a series of life-saving action that improve the chance of survival following cardiac arrest that involve rescue breathing and also chest compression. In children at the age of 1 year to approximately 5 years old. So for indication, usually we done CPR in cardiac arrest or pulseless, respiratory insufficiency, and also bradycardia, heart rate less than 60 beats per minute, with a pulse and also for perfusion. So for complication of CPR, can cause rib and stomach fractures, pneumothorax, contusion, and also aspiration. So next slide. So for equipment, we usually can have a PPE if available, such as a glove, aprons, and also mask. And then we need to have a mask device and also automated external defibrillator. Next slide. So for techniques of CPR, we use doctors ABCD. So for doctors ABCD, D for danger. So first of all, we need to wear PPE, look out for any hazards that can harm the victim and also the healthcare provider. And then response, we need to check the child for a response by asking them to open their eyes or squeeze healthcare provider, and also we can tap the shoulder of the victim and ask, "Are you alright?" If there is no response, and then we need to stop the app and also call for ambulance and defibrillator. Next one. So for okay, so for airway, we need to check the child's mouth for airway blockage, like the tongue, the foot, vomit or blood. If there is a blockage, we need to roll the child to their side, keeping their leg bent, or we call it as a position. And then we need to clear the blockage with fingers, and then we need to check chain for the breathing. And also we can open the airway by performing a head tilt and chin lift. So for breathing, we need to look, listen, and feel for breathing. If there is a breathing, we need to give a 5 rescue breath. Okay. So for circulation, we need to look or sign of life by checking carotid pulse in child that so if there is no signs of life, we can start chest compression. And then after the EED has arrived, we can attach the EED and also follow the EED voice prompt. So next slide. So for chest compression, we need to compress the lower half of the sternum with the heel of one or two hands. For the location, it is approximately fingers breadth above the ZP sternum. So the sternum should be depressed at least 1/3 of anterior posterior diameter or around 5 centimeters or 2 inch. And then we need to minimize interruption during chest compression, and we must allow complete recoil of the chest. The rate should be between 100 to 120 compressions. And then the compression to breath ratio is 32. We have to do 30 compression and then we give 2 breath. So next slide. So for recovery position, if the victim is still unconscious but can breathing, we can put the victim recovery position, and then we need to check regularly. And by the time, we also need to make sure that there is a comfortable space for the victim to breathe. Next slide. So this is algorithm. So this one I took from book Department of Anesthesiology. So you can review it later. Okay, I think that's all from me. There's a video. You can see. Dengar tak? Kalau tak dengar tak apalah, dengar sendiri nanti.
Okay, can you go to your previous slide? There are a few things that different lah basically. So actually, for the CPR in children or in infant, okay lah, for equipment it depends lah where you are lah. If you find patient unconscious outside from the hospital, maybe you don't have your PPE, you don't have your bed mask, or you don't have a AED. So if you assume that, okay, next slide. So this one for the technique, it's not much different, but usually we don't say lah danger, respond and shout. Usually in pediatric life support that what we teach here, and then I think that one will be standardized throughout the country. It's just similar, but a bit different lah. The first step is 3S: safety, stimulate, and shout. It's about the same basically. Danger, wear PPE, but we say it's safety lah, safety for the patient and safety for us. And then we stimulate the child. Okay, we ask lah, baby or boy, are you alright? If no response, we shout. And we shout for help. If you are outside the hospital, if you are inside of the hospital, so of course we assume that the safety is safe, and then you simulate the child, and if not respond, you shout for help lah. You ask your other colleague to come. And then next. Okay, so after you shout for help, you try to open the airway. So in children, we use head chain lift and put a patient on sniffing position. Head chain lift in sniffing position. Kalau budak, kita neutral position lah kalau baby. And if patient have, for example, trauma patient, we advise that we don't do that. To open the airway, we not use head chain lift. Just put on patient on jaw thrust. But at the same time, we need to secure the spine. And the breathing same, listen, feel. Look for the chest movement, listen for the breath sound, feel for exhale air. So after if no breathing, we give a rescue breath. So after 5 rescue breaths, we look for the circulation, like you mentioned, look sign of life. So what is the sign of life? What is the sign of life?
And feel the breathing.
Sorry?
Fill the cardiac pulse.
No, no. The one and now, if you are outside the hospital, for example, you found patients lying unconscious outside from hospital. Now we don't advise to check we don't advise to palpate for the pulse because it took time. And imagine if we teach layman person who didn't have any medical background, you ask them to check the pulse, maybe he took about more than 1 minute, 2 minutes, 3 minutes just to check for the pulse. So we just look for any sign of life. For example, if there any movement, any chest movement, any physical movement, or any gurgling sound after we give 5 rescue breath. If none, we initiate the CPR. And then if you want after you start the CPR, usually the ratio now we teach that about 15:2. It's not 30:2 lah. Even you are 2 rescuer ke, single rescuer ke, dia 15:2 sahaja. So 15 ventilation, 2 breath. And then if you are in the hospital, of course, after that you have to put on the chest lead. So next slide. Okay, for the chest compression, like you mentioned, it depends on if bigger children, you use your heel lah, but use 2 hand lah. Like in the video shown just now, right? Put 2 hand, right? On top of your hand tu ada 2 tangan kat situ lah. So sama je, location sama, lower third of the sternum, and then depth to 1/3 of the epidiameter, and then cuma ratio tu lain. Compression to breath ratio 15:2. Rate tu sama 100 to 120 compression per minute. So if okay, next slide. Okay, that one your recovery lah. So basically this depends lah where you are. If you outside of the hospital, that you do lah, and then you wait for the ambulance. But you need to call for help earlier. If you are in the hospital, patient already brought to you, the algorithm is the same. 3S, safety, stimulate, shout, look, listen, feel, 5 rescue breaths, and then look any sign of life. If no, start chest compression, and then at the same time you put patient on cardiac chest lead, because you want to know whether we want to identify what is the rhythm, whether it's shockable rhythm or non-shockable rhythm. For example, patient came in collapse, so it can be asystole or patient PEA, pulseless electrical activity. That one is non-shockable rhythm. If shockable rhythm, for example, your VF, VT. So you have to identify lah for further management. If patient asystole or PEA, you continue CPR, try to get line, and immediately give IV adrenaline. If shockable rhythm, VF or VT, you have to shock the child, 4 joule per kilo, and then you give adrenaline, and then you give your amiodarone, and then you have to consider your 4H40, the irreversible cause of patient collapse. Later you look lah what is 4H40. Okay, understand lah? Clear ke?
Clear.
Faham? Okay.
So now kita tak ada dah, kalau you look at your algorithm tu, kita tak ada dah check pulse tu. We don't teach them check pulse. Just look for any sign of life. Any movement, any gurgling sound, any breathing. Okay. Okay.
Okay, boleh.
Thank you.
Okay, Doctor. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I'm going to present about CPR in infant. I think it's pretty much similar to the previous topic, and I'm based on after what Doctor have explained just now. I think there might be a few mistakes in my slide, so it's okay. We'll correct it along the way. Okay. So how to move this slide? Okay, so for introduction, so CPR, as Aisha mentioned just now, is a cardiopulmonary resuscitation. So as compared to adult, respiratory arrest is more common in children. Most of them will develop respiratory arrest and bradycardia before the cardiac arrest. However, cardiac arrest can occur in children with pre-existing cardiac condition. So patient might have high survival rate if immediate CPR is given. In a case of witness arrest, like there's you and another person, so you can call for help first before the CPR to get a defibrillator. But in a case where you are alone, so you need to give 5 cycles of CPR first before calling for help. So in hospital, usually we have someone to help us lah kan. So in this part, I'm going to explain for infants, so age 1 month to 1 years old. So
Sorry. Can you go back to your previous slide? What do you mean by administer 5 cycle of CPR? You mean compression plus breath?
kalau kat sini compression and breath, lepas tu baru we give the defibrillator tu. Maksudnya baru after that baru cari.
This one outside the hospital lah.
Outside the hospital.
So actually dia that's why kalau tengok sini I tak tahu bila you call for help tu you initiate CPR first and then you call for help. Is it?
Kalau yang according to this book, it says give 5 cycles and then baru sorry doktor.
Lambat.
Oh, okay.
So dia kena follow algorithm tu. You safety, stimulate and shout. Shout tu shout for help lah. And then you kena follow balik. Look for sign of life, look, listen, feel. Kalau tak ada 5 rescue breath dulu. Sebab most of the time baby dia beza dengan orang tua. Most of the time patient collapse due to cardiac problem. For example, due to coronary artery problem lah. That's why the compression tu dia akan tekankan pasal compression. But in children, most of the time is due to respiratory failure. And then both can cause cardiac arrest, respiratory and circulatory failure. So both of this failure can cause cardiac arrest. But most of the time, the children is due to respiratory failure. So that's why we don't initiate the CPR first. We try to give a 5 rescue breath. Some of them will get a spontaneous breathing after that. And then of course, after your spontaneous breathing, your heart rate will become up. If no, after you 5 rescue breaths, you check for sign of life. There is no sign of life, you straight away initiate the CPR. And then you call for help again lah. Kalau you seorang waktu tu, you dah call for help awal-awal kan. And then after you 5 rescue breath, before you initiate your CPR, you already call kalau tengok algoritma yang kita punya, dia akan suruh kita call the emergency department service via loudspeaker. And you kena call balik using the loudspeaker lah. Sebab kalau you nak buat dulu and then you baru call, lambat lah. Okay. Okay.
I'll correct that part. So indication dia similar like Aisha just now. So cardiorespiratory arrest, bradycardia, less than 60 beat per minute with poor perfusion. And then
Betul.
Okay. And then I'm going to explain about how we're going to check for circulation. And then I think this one is similar to what Dr. has explained just now lah. Basically macam we for circulation part, like the pulse itself cannot determine whether the patient is effective or inadequate circulation. So we need to look for any signs of life.
Yeah.
Okay. And
so that's why they remove. Previously in the algorithm, yes, check for any sign, check for the pulse. But we know that hakikatnya memang susah lah. And then you will delay your CPR. That's why they remove, they just look for any sign of life. Okay.
Okay, and then again for equipment, depends on where we are. So the PPE is going to vary according to that. And then the back glove marks and AED. Okay, and then so for this part, we're going to use the SSS.
safety, shout, safety, stimulate and shout. So not the DRS, okay? Right. And then we go for the airway. Again, in infant, like Dr. mentioned just now, it's not supposed to do head pitching lift. We are supposed to put it in neutral position for infant, okay? And I'm going to correct this part, okay, before I send the slide again. Okay, and then we look for the breathing. So for breathing, similar like previous part. So look, listen, and feel. So this part is where you give the 5 rescue breath. Okay, so for look for chest movement, listen for the breath sounds, and feel for air movement on the cheek. So basically baby kat sini kan, so kita letak kepala macam ni, so kita boleh nampak the chest is moving, and then we can feel the air, and we listen to this breath sound lah. And then we proceed to C. C is the circulation. So for this part, according to what I've quote from this book, it says that in infant, we look for the brachial pulse rather than carotid. And so for infant, we look for the brachial pulse on the inner aspect of the upper arm. And then if the pulse is absent or less than 60 beats per minute, then we start the chest compression. And then for defibrillation, we need to assess whether the patient need the shock. Okay, and then what are high quality chest compression in infant? Again, 100 to 120 compression per minute. 4 cm depth for infant is uninterrupted, and we allow spontaneous recoil of the chest wall. And then for the compression in infant, so first we need to identify the landmark to the compression, which is at the lower sternum. So where is it? Is approximately a finger breadth above the xiphisternum. So in a case of lone rescuer, like there's only you, so you can compress the xiphisternum, the lower sternum, with tip of your 2 finger, like the picture shown in B. Okay, and in the case of 2 or more rescuers, so we can use the encircling method. So encircling method is the one in E. So so for this part, doctor, so we just use the 15 2, right? Because okay, what I quote from this book, it says 1 rescuer 30, 2 rescuer 15, but actually we just do 15 2.
15-2 je semua.
Okay, so okay, I'm going to correct this part as well. Okay, and then so recovery position for infant, like there's many ways for you to do it. Either you can just hold the infant in your hand, so make sure the head is lower than the body level, or you can actually put, like in this picture, you put the infant on a bed, but put something like macam blanket, or roll blanket, or roll towel, anything to stabilize this patient lah macam tu. So but what are the important principles? Basically, we put the infant in a near true lateral position because we want to enable drainage of fluid from the mouth. To ensure stable position, no pressure to the chest that might impair the breathing, and then the airway is accessible and easily observed. Okay. And then, so for complication, it's similar, bruises, aspiration, rib or sternal fractures, pneumothorax, precardial tamponade, and aortic laceration. So for the video, I've provided the video YouTube link there, so you can just click on it. But again, because I took the video previously before I know the knowledge just now, so might be some mistakes lah, especially during the 30 compression to ventilation concept too. So supposedly 52. So my reference are the CPR book from actually written by our lecturers in anesthesiology department. So I have the hard copy if anyone want to borrow it. So that's all from my part. Thank you.
It's not a mistake lah. Basically, before that we do about the ratio is like you mentioned lah. But now after a lot of study was being done, and then they come out with this ratio 15-2, because more ventilation was given. If you give 30-2, so the ratio is for the ventilation part is less lah. If you give 15-2, so double the ventilation, because like I mentioned and you put on in your slide, the most common score is respiratory, right? Compared to the adult, yes, cardio is the problem. So that's why the chest compression is more compared to the children. Okay. Okay. Any presentation after this? Ada lagi ya?
That's the
Mungkin ada.
last part of our seminar. Thank you.
Any question ke regarding the procedure? Have you seen any CPR patient or any doctor do the CPR in pediatric patient?
For me, I've never seen actually lah.
We
just
also
a
never.
stimulation on mannequin.
Because I think last week I conducting one training program lah for the MPLS, Malaysia Pediatric Life Support. So we do this simulation but that one for the houseman and the junior medical officer. So later you have the opportunity to see and do lah. But nice to have the knowledge first. Okay. And any other question? Tak ada.
So far tak ada, insyaAllah.
Okay. Nanti share you punya slide after you correct lah.
Okay, Doctor, will do.
Okay, Doctor, boleh.
Thank you, Doctor.
Okay.
Thank you, Doctor.
Thank you for your attention.
Thank you, Doctor.